Good afternoon, everybody. Thank you so much for joining us today for our session on immunosuppressive treatments and the COVID-19 vaccine, sarcoidosis immunosuppressive treatments and the COVID-19 vaccine. I'm Mindy Buchanan, the Director of Patient Programs with the Foundation for Sarcoidosis. And before we start, like every other time this week, I have some housekeeping items. So a reminder that this session is recorded and will be available until August 13th inside the Summit platform. We will be addressing questions at the end of the presentation, but go ahead and drop them into the questions section as you have them, and we'll try to get to them. We imagine there's going to be a lot of questions, and we will try to get to as many questions as possible. And we also know that this is a super hot topic, and today's session will be sort of specific about immunosuppressive treatments for sarcoidosis and the vaccines. Just as a reminder to try to be as broad as possible when asking your questions, we know that sarcoidosis is unique, but it's important to note that our experts are not able to provide direct medical advice. With that, I want to introduce Dr. Matthew C. Baker. Dr. Baker is the clinical chief in the Division of Immunology and Rheumatology at Stanford University. He received his bachelor's degree from Pomona College, his medical degree from Harvard Medical School, and his master's degree in epidemiology and clinical research from Stanford University. He completed his internal medicine residency at Massachusetts General Hospital and his rheumatology fellowship at Stanford University. Dr. Baker has established a clinical research program that focused on clinical trials and bench-to-bedside translational research. He has designed and led investigator-initiated studies with focus on sarcoidosis, Sjogren's syndrome, and IgG4-related disease. He is the founder and co-director of the Stanford Multidisciplinary Sarcoidosis Program and collaborates with other team members to advance sarcoidosis clinical care and research. Welcome, Dr. Baker.
Thank you. Thanks for having me. Thanks for that very kind introduction. And thanks to the FSR for putting on this important patient summit. Let me see if I can advance. There we go. So yeah, I'm here today to talk to you all about sarcoid and how it relates to COVID and specifically the vaccines. And I know this is a topic on many people's minds. So I'm hoping that I can provide you with some data that will help empower you to better understand some of the decisions that are being made on this topic. So I'm going to start with a presentation so that I can really sort of present the data and help you understand what we know, and then leave ample time at the end to address questions. And again, this is really, I'm hoping to be kind of a data-driven presentation so that you can see what's really out there and better make decisions for yourself, and also provide you with many answers of what we don't know, unfortunately. So just to start, and I think everybody's well aware of this at this point, but what we're talking about is the SARS-CoV-2 virus, which causes what we call COVID-19 or coronavirus disease 2019. This schematic shows the virus, which, just to point out, has nuclear information inside and then what we call the spike protein on the outside. And that spike protein binds to something called the ACE2 receptor, which is expressed on human cells, which enables the virus to get into your cells, and it primarily causes a pulmonary or respiratory disease like these x-rays show. What we've learned over the last year and a half is that really everybody is susceptible to this infection, but there's an increased risk for severe disease or death. Early on, we learned that men, especially older men with comorbidities, were at high risk, and then in the US, Black, Hispanic, and South Asian individuals as well. And we've more recently come to understand the importance of underlying lung disease and immunocompromised states in the susceptibility, and that's a lot of what we'll talk about today. That all being said, sarcoidosis is a rare disease, so there's very little sarcoidosis specific data. Most of what we know, we are extrapolating from other similar conditions or patients with similar immune states. So the first question that comes to mind, I think, for a lot of patients are just having sarcoidosis, does that make you more likely to contract the virus? Not necessarily how severe your disease will be, but just get it. And I would say that's a really hard question to study because you can never account for patient behavior in these types of studies. So, when this all first happened, if you were a 50-year-old person with sarcoidosis, you might have been much less likely to go out and do things that might have been a little riskier in terms of being exposed than somebody who knew they didn't have sarcoidosis. And so when you just look back and observe at rates of infection, you can never really account for how patients might have modified behavior, understanding that they had an underlying disease. I commend Dr. Boffman and others who have done studies at the beginning of the pandemic to try to understand the rates of infection among sarcoidosis patients. This was a questionnaire study that was done last year, April to July. At that time, it did show a potentially increased rate of COVID in sarcoidosis patients compared to the US rate at the time. But in that study, when they looked at a smaller subset of the patients in the same area over the same time, it really looked to be pretty similar. Another small cohort showed a similar rate of about 2.1% of sarcoidosis patients contracting COVID early on in the pandemic. But I think, after seeing these studies and seeing how the last year has played out, and again, understanding the limitations of these kind of studies, I don't think that any of us would say that there's an inherent risk to being more susceptible to getting COVID-19 from sarcoid. I think the next topic, which we'll talk about, is can it be more severe in patients with sarcoid? There's some better data for, but I don't think we have very compelling evidence that just by having sarcoidosis, you're at a much higher risk of actually contracting the disease. But the next question that's probably more important is, if you were to get COVID-19 as a sarcoidosis patient, are you more likely to have severe disease? So again, there aren't a lot of studies. Unfortunately, it would be great if we could amass all the sarcoidosis patients in the world and just study them and understand what's happened to them if they contracted COVID-19. That has been done in other areas within rheumatology. So there's a global rheumatology alliance, which has amassed many thousands of patients with autoimmune diseases, and we've been studying their outcomes. So this was a study early in the pandemic of 600 patients. And you can see the most common diseases. So these are other diseases like rheumatoid arthritis and lupus. This study did actually include 10 patients with sarcoidosis. And the goal was to figure out how these patients did compared to others. And this is kind of a summary of the risk of being hospitalized. So these are patients who developed COVID-19, and then what was the risk that they got so sick they had to be in the hospital? And the clear risk factors that came out of this study were patients with immune disease that also had underlying lung disease, and patients who were on steroid medicines like prednisone, especially at higher doses. And this figure shows that what we call the odds ratio, where 1 means there's no increased risk, and if it's to the right, it's a higher risk. So you can see patients who have immune-mediated diseases who were on steroids, who have lung disease, and some of the other risk factors that we've figured out over the year, that if you're older or have comorbidities like high blood pressure, those patients were more likely to be hospitalized. And I think a lot of sarcoidosis patients probably fall into this category. More recently, as more cases accrued in this global database, we were able to look at a rare endpoint, which is death. So this looked at several thousand patients, some of who were deceased and some who were not. Unfortunately, this study didn't specifically call out sarcoidosis patients, but again, these are patients with conditions that involve the immune system and that are treated with similar drugs to those used in sarcoidosis. This kind of other rheumatic disease group probably did include some sarcoidosis patients. And again, we're looking at the odds now, instead of just hospitalization, but of actually dying from the disease. And you can see, once again, age is a very strong risk factor for having more severe outcome, in this case, death, as well as lung disease, not as high of a risk factor as age, but definitely there, along with the comorbidities that have been described, such as high blood pressure. And this study also looked at, based on what medications these patients were taking, what their potential risk for death from COVID was. And this study was one of many that has shown that rituximab, which isn't super commonly used in sarcoidosis, but definitely is used. It's a drug that depletes your B cells, which are the cells that make antibodies. And this study showed that patients who had received rituximab had the highest odds or increased risk of dying from COVID. Also patients on steroids, although it wasn't as extreme. And I think what was reassuring about this study was that it showed that TNF inhibitors, which are fairly commonly used in sarcoidosis, didn't show an increased risk of death. And other immunosuppressants and things like methotrexate also didn't show a significant increase. And this is the most recent study to come out from this database. This only looked at rheumatoid arthritis patients. And again, just to say, now there are many thousands of patients who have been treated with these medications who have contracted COVID. And really, it's rituximab that seems to be the biggest concern in terms of having outcomes which are listed on the left here, such as being hospitalized or dying, with very high odds ratios, meaning 300, 400% increased risk of these outcomes for patients on rituximab compared to things like TNF inhibitors, which at this point we don't think really confer an increased risk. So that's one area we can learn from are other patients with immune-mediated diseases. And the other area that's been studied in some detail are patients with lung disease in general. And that breaks down into things very different from sarcoidosis, like COPD and asthma, or things like lung cancer. But this study also did include 17,624 patients with sarcoidosis. These were out of a pool of about 8 million patients in England. And they captured about 15,000 who were admitted to the hospital with COVID. And this showed, looking at the risk of hospitalization from COVID, there were 84 patients with sarcoid who were hospitalized. And in these adjusted analyses, this basically allows you to compare everything else being relatively similar. So compared to somewhat healthy control patients of similar age and sex and with the same comorbidities, just the addition of sarcoidosis increased the risk of being hospitalized by about 36%. So having these underlying lung diseases definitely seem to increase the risk of having hospitalization from COVID. They also looked at ICU admission, and again, and this was increased in sarcoidosis patients, although the number is very small, only 10 patients, but with an increased risk of about 50% of ICU admission and of death. Again, the numbers are quite small for a study like this, 32 patients, but we do see that the underlying sarcoidosis in these patients probably increased their risk of having this bad outcome of death from COVID. And one last small study from Southern Europe of 45 sarcoidosis patients. This study, these patients may not be your typical as sick kind of sarcoidosis patients, as only 17% were listed as having chronic lung disease and only 62% were on any type of immunosuppression. But I think the point here is that, again, age is one of the biggest risk factors when you're thinking about any patient population, including sarcoidosis patients. So looking at the dark color, which is ICU or death or needing to be ventilated, those go up as your age gets to 75, and the younger patients were mostly just treated at home. So I think to answer this question, do sarcoidosis patients get more severe COVID-19? Based on the data, now you've seen all the data that I've seen, I would say that there likely is an increased risk for more severe disease if you contract it, but each patient is an individual patient, and there's really a spectrum, and it depends on a lot of those factors that we just went through. So older age, comorbidities like high blood pressure, heart disease, diabetes, how involved your lungs are. I don't think we know if your lungs are just a little involved or a lot involved, how much of a degree that makes a difference, but it probably does. And then certainly what treatments you're on. And we know that rituximab and moderate to high doses of steroids are probably the biggest risk factors. I think the other question that comes up a lot, because methotrexate and TNF inhibitors are used frequently in sarcoid, is that the data so far has not suggested that those are major risk factors for having severe COVID, which I think is very reassuring. Another key question then is, should sarcoidosis patients get the COVID-19 vaccine? And I think this is a super important topic. And I think to really understand it, you have to have a little basis of immunology and how the vaccine works. So just to kind of break down the immune system as simply as possible. There are kind of two arms, the innate immunity and the adaptive immunity. The innate immune system includes cells like these cells here called dendritic cells, and the adaptive immune system includes B cells and T cells. Everything on this side is sort of more primitive. They kind of patrol your body. They try to find bad things and help start the response, but they aren't very specific and they don't provide memory that will protect you long term. On the adaptive side, the B cells and T cells, they learn over time and they evolve and they provide long-term protection and memory. And so these are the cells that ultimately the vaccine is going to augment and enable you to have long-term immunity. And that's kind of summarized here. So again, these dendritic cells we call antigen presenting cells. They kind of pick up the bad materials and present it to these B cells and T cells. The B cells make antibodies, which you can see help to bind and neutralize the virus in this case. And the T cells are necessary to help the B cells. And then they can also, a form of the T cells can directly kill any cell that's infected by the virus already. So you end up getting antibodies to block the virus from getting in cells, and you get T cells that can kill the virus inside of cells. And when we think about vaccines, there's sort of three main approaches. There's using the whole virus, there's using just the protein part, like the spike protein, or there's giving just the genetic material. And for the three authorized vaccines in the US, currently the approaches are using the genetic material. And just to understand this on a basic level, I think is important. So this is a schematic of the coronavirus. As I mentioned before, it uses this spike protein to get into the cell. So the goal of the vaccine is to provide an immune response that will block this spike protein. And inside the virus is genetic material, a portion of which tells the virus to make that protein. So these vaccines use that genetic material, and there's basically two approaches. The first is like the Johnson & Johnson, which uses adenovirus, which is the common cold virus, to get the genetic material inside your own cells. In this case, it's DNA, so it has to actually go in your cell's nucleus and be transcribed into mRNA, and the mRNA can then be used in the cell to produce the protein. The mRNA vaccines, such as the Moderna and Pfizer, kind of skip that step, and they actually just give you the mRNA straight in a lipid nanoparticle. So all that has to do is enter the cell, and it never has to go in your cell's nucleus. It can just be transcribed or translated into a protein. And now your own cells are actually expressing this kind of weird protein, the spike protein that's on the coronavirus. And that's how you get your body to recognize it and start to make a response to it. So the next step is that those cells die, they release those spike proteins, those antigen presenting cells we talk about pick them up, and they show them to T cells. And then those T cells are critical for helping B cells to also recognize that and start to make antibodies. And so ultimately what you're left with is B cells making antibodies that block this protein and bind up the virus so it can't get in cells. And you're left with a subset of these T cells that we call killer T cells that can actually recognize any infected cell that might be expressing that protein and kill it. And so therefore get rid of the virus inside the cells. And so there's a lot of questions about safety and use of these vaccines in patients with autoimmune diseases. This is another kind of summary of the different types of vaccines. And I would say all of these vaccines are safe for patients with autoimmune disease, including sarcoidosis, except for live attenuated vaccines. And fortunately, those are really not on the table. So we're going to kind of go through the available options right now. So in the US, there are 3 that are authorized for emergency use. The 2 mRNA vaccines, the Pfizer and Moderna, and then the adenovirus vector, which is the J&J. Worldwide, there are 17 approved vaccines and many more candidates in early phase studies. These are the most commonly approved and used across the world right now. And again, just to highlight that the mode of action are either these mRNA, the adenovirus vector, or what we call inactivated. And I think there were some questions coming internationally from India and other countries where some of these inactivated vaccines are used to understand if they're safe. And so I just wanted to touch upon that briefly. So all of these are safe for patients who are immunocompromised, including the inactivated vaccines. The way that the inactivated vaccine works is that they actually kill the virus completely. And so it cannot replicate, it cannot cause disease. Even if you had no immune system, the virus could not take over. And that's, again, what some of these in China and in India are being developed. There are, in the history of vaccines, other vaccines that are known as live attenuated vaccine, where they actually keep the virus alive, they just weaken it. And for that vaccine to work, the virus does actually have to replicate in the person. In a normal, healthy person, it causes no disease or maybe very, very mild disease. But there are reports of these types of vaccines actually causing severe disease in patients who have an immunocompromised state. But looking at this tracker of all the vaccine candidates, there's only one out of the 123 that's listed as a live attenuated, and it's in a phase 1 study in the UK. So I don't think for anyone on this call, there will be any concern that any vaccine available to them is a safety concern. So I wanted to make that point really clear. So I think that they're safe, and I think that they're highly effective. I'm sure most people have seen the schematic that this cartoon kind of summarizes, which just showed how amazingly effective the vaccine group did compared to placebo, particularly in the mRNA vaccines, where there was a 95% reduction in COVID-19 compared to the placebo. In order to get full protection from these, you do need to wait 2 weeks after the second shot, but if you do, they're highly effective. The J&J vaccine was studied at a slightly different time with a higher COVID incidence and in different countries, so it's hard to directly compare. The rate of protection was a little bit lower, but it was still very effective. And most importantly, it still prevents severe disease and death, which is the most important thing. And this, again, requires 2 weeks after the one shot. There are some side effects with the vaccines. We have not seen anything specific to sarcoidosis patients. You should expect mild things like pain in the arm, redness, swelling, fever. Generally, patients report these lasting 12 to 24 hours and generally gone within a few days. There are very rare reports of more severe adverse events. At this point, there have been so many millions of doses given that things like this are bound to emerge. Very rare reports of anaphylaxis, of blood clot syndrome with the J&J vaccine, a few cases of myocarditis, and then some deaths have been reported, although no causal links to the vaccines established. I think some questions had come in around the myocarditis and whether that is in any way related to cardiac sarcoidosis. And I would say that it's really not. It's this myocarditis that has been seen related to the vaccine appears to be occurring in young people, almost all of which are 30 or younger. It's very acute onset with chest pain and elevation in the troponin blood test, and then resolves very quickly too. And I think all of these patients have had pretty much complete resolution within a few days of this kind of acute process. So it's not, we have no evidence or concern that this is somehow triggering cardiac disease and sarcoidosis. A shout out to FSR for doing this survey study. This was done earlier back in February. And at that time, 292 sarcoidosis patients responded to this survey. And at that point, about 60% had been vaccinated. This was early when a lot of patients still weren't eligible. And so I think we're all hoping that many more have been vaccinated since then. But there were, safety concerns at that point, which is understandable. This is all new to a lot of us. But I think it was reassuring that for most patients, the symptoms that were reported were really kind of what you would expect, with sore arm, fever, fatigue, and flu-like symptoms, and nothing particularly notable or adverse came out of this survey. So in terms of the summary of whether patients should get the COVID vaccine, I think from my perspective, it's a very clear yes. Is there a concern that patients will flare? I would say no, we really have no evidence of that. And is there a concern that patients will not have a strong response to the vaccine because of their sarcoidosis or their underlying treatments? And I think that is a maybe that requires a little more discussion. So first, just to briefly touch upon the issue of flaring, again, I think we have no evidence at this point that the vaccine has led to any notable flares in sarcoidosis. In rheumatology, the disease that most of us were concerned about in terms of the vaccine inducing flares is a disease called lupus. And that's because lupus involves a lot of pathways that viruses also use. So viruses definitely can trigger lupus flares. And there was a concern that the mechanism of these vaccines could potentially lead to some flares in lupus. So it's been studied in lupus. It hasn't been specifically studied in a big cohort of sarcoidosis patients. But I think it's very reassuring what we've seen in lupus. And this was a study that at this point has almost 600 lupus patients who have been vaccinated, many of which had mild side effects, as you would expect. But on the right here, you can see of all of those patients, there were 20 that had medically confirmed flares, which is about 3.5%. And again, this is in a disease where we sort of expected that this might happen to some degree. So my guess is that in a disease like sarcoidosis, it would be well below 1% of patients at the end of the day that might experience some type of flare secondary to the vaccine. And then I think the more pressing question that I'm sure a lot of you have is, what will the vaccine do in you as a sarcoidosis patient, and depending on what your treatments are. And so again, I would love to say that we had a big study of 5,000 or 20,000 sarcoidosis patients who have all received the vaccine and we could measure their response, but that doesn't exist. So we have to extrapolate from the data that does exist. Those are patients who have other diseases that compromise the immune system, such as cancer, those that have had organ transplants, or other patients with immune-mediated disease. It gets a little complicated because it's actually not so straightforward to just say you had a response to the vaccine. You have to really understand how that's measured. And I think the two most important things are the antibody tests, which are relatively simple to do. This schematic kind of shows you're basically just taking blood and literally measuring a protein, which is the antibody in the blood, by putting it in a dish. So this is very stable. It's very easy to do. There's a couple different ways to do it. You can look at how it binds to the virus or how it actually neutralizes the virus. The biggest downside to these antibody tests is that right now, nobody knows what the numbers mean. So when you do a test like this, you end up getting a titer or a level of antibody. And at this point, we don't know what number a patient might require to actually have functional protection against the virus. So just to use arbitrary units, one patient might have 10,000 and one patient might have 30,000. And so the patient with 10,000 has a threefold reduction, but maybe you only need 5,000 to have complete protection against the virus. And right now, there's nobody who can tell you what these numbers mean and what's meaningful. And so until we have those numbers, the antibody test is hard to interpret. The other side of the adaptive immune system, we talked about the T cells, are also important in protecting you, but they're much, much harder to measure. And just as a schematic, the test to measure T cells is much more complex. You have to have live, viable cells. You have to stimulate them with specific antigens, and then you have to measure their response and see what kind of cytokines they produce. And so this type of test is very challenging to do. It's not available just in most clinics. It's mostly done in the research setting. And again, we don't really have any way to interpret the end results. Very hard to know what the T cell tests mean. And then within the antibodies, it's important to know that not all antibodies against SARS-CoV-2 are the same. So a lot of the initial tests that were done for looking at antibodies were against what we call the nucleocapsid protein, which is inside the virus. And that is something that will develop if you have a natural infection because you're exposed to the whole virus. However, if you were never infected with the virus and you get a mRNA vaccine, which is just producing this spike protein, you'll never develop antibodies against antinucleocapsid. So conversely, if you're looking for a response to the vaccine, then you would hope that you would have S protein, or the spike protein, which is what the vaccine is producing in your body. And there are multiple different tests that get reported out. Some tests look at the entire protein, some look at just the S1 or S2 domain, and then you may see test results called anti-receptor binding domain, or RBD, which really just looks at the interface of the protein that interfaces with that ACE2 receptor. And then the third kind of nuance to this test is that even if you detect antibodies, there are some antibodies that might bind this protein, but actually not prevent the virus from getting into your cells. And then there are other antibodies that bind in a place that really do protect you. And so there are tests that just look at straight binding and just tell you, does the antibody bind to this protein? And there are other tests that say, if we put cells and the virus in a dish and we add the antibody, can we actually prevent the virus from infecting the cells? That's what we call a neutralizing test. And so that type of test looks specifically at the ability and function of the antibodies to neutralize the virus's effect. So I don't want to overwhelm with too many details, but just to say that it's not so straightforward to just call everything an antibody test and think that it's one simple thing. You could go to 5 different labs and get 20 different tests, and it could all tell you very different information. And at the end of the day, really the interpretation of that is what the challenge is currently. But there have been studies that have looked at how patients who are on immunosuppressive medicines or in immunocompromised states, how they do respond to the vaccine. This is a study that looked at about 20 patients with solid cancers, like GI tumors, and they showed that after the second shot of an mRNA vaccine, about 95% were what they considered antibody positive to the spike protein, suggesting that they mounted an adequate response. They also looked at T cells and showed a pretty robust response again. So this test, in these types of studies, we don't actually know the exact thresholds that they're using to say someone was positive. And again, we don't know if it's meaningful. But I think the cutoffs they chose to use in this study at least are reassuring that patients were responding to the vaccine appropriately. However, there are other studies, and these studies in organ transplant patients have been in the news a lot because these showed that patients who had received 2 doses of an mRNA vaccine, many of which are on treatment with CellCept, which is sometimes used in sarcoidosis, actually only 54% had what they considered a meaningful amount of antibody response about 3 to 4 weeks after their second shot. And so in this population, it appears that the vaccine may not be as effective. Also, in patients with hematologic malignancies like chronic lymphocytic leukemia, this study showed a response of about 52% of patients had antibodies. Again, I just point out that everybody's using some threshold to say what's positive and what's meaningful. And I don't think anybody knows that that's really been established. And so it's hard to compare across studies and populations. But I think, the investigators felt compelled to present it in a way that really suggests that a significant proportion of these patients are not mounting an adequate response. And so what about immune-mediated diseases? So this is one of the earlier studies that came out, 26 patients, one of which had sarcoidosis, on infliximab or Remicade and 15 milligrams of prednisone. Of course, we don't know individual patient level data from this study, but it was very reassuring to see that of the 26 patients with inflammatory diseases compared to the 42 healthy controls, that really almost everybody had a strong response. This is the amount of IgG or antibody produced and neutralizing antibodies. Of course, there are a couple of people here who had lower responses, and we don't know which diseases those were from. But on average, patients with these immune-mediated diseases did well. In that study, they also had no difference in side effects compared to the healthy controls, and none of the patients had a disease flare from the vaccine. And then probably the largest, what we would consider in rheumatology, most important study at this point was one done recently looking at about 133 patients with inflammatory diseases. In this case, it included things like inflammatory bowel disease, rheumatoid arthritis, lupus, MS. So these are, of course, different than sarcoidosis, but the most commonly used drugs were TNF inhibitors like Remicade or Humira and methotrexate, which are two of the more commonly used drugs in sarcoidosis. And this study found that, kind of as expected, if you've been on a B-cell depleting drug like rituximab, those patients had a very significant reduction in their antibody titer, so the amount of antibody produced. In addition, if you're on glucocorticoids, and in this study, they found that it was not dose dependent, meaning even low doses, 5 milligrams of steroids, the response to the vaccine was quite a bit lower. But what was reassuring was that they found methotrexate, which is kind of grouped into the antimetabolites, and TNF inhibitors, and those patients on a combination of both. They did have a reduction, but it was quite modest, and still had very robust response to the vaccine. And they didn't say what their kind of threshold or cutoff was for calling someone positive, but they reported in the text that 98% of controls were positive. 92% of all those patients they considered positive if they were off prednisone, and those on prednisone, that dropped to 65%. So this study, I think, was very reassuring in the sense that methotrexate and TNF inhibitors did not have a significant impact on the response to vaccine. Rituximab did, as we kind of knew it would. And I think maybe of surprise was the degree to which steroids also reduced the vaccine response. And so this is just a summary of those studies, but looking at other kind of comparator groups, I would say that actually patients with immune-mediated disease seem to do better than a lot of these either cancer patients or post-transplant patients. There is a reduction in antibody titer, but for most patients, I think our best guess is that it's not a meaningful reduction, that it's probably still protective. And so again, this is just kind of more a summary of that. I think that, to make the point that even if there is some reduction in response, it's very, very likely that these vaccines are still providing very meaningful protection and can potentially be life-saving. And it highlights how much we don't know still about what it means to have a reduction in your antibody titer. So that's really the area that needs the most exploration right now, is understanding what those thresholds are, what level of an antibody response do you need to really be protected. And until we get that information, it's hard to know if there's concern from the studies that have been published so far. So that leads to the next question, which I think everybody has, which is, should you get one of these antibody tests? And I would say my answer is probably not. I think it's a very reasonable question, and I would have the same one if I was a patient in this situation. But I think that the problem is when you get the answer, you have no idea what to do with it. I think the example I laid out before, I think is a perfect one. So if a normal person has a 30,000 unit response and you go get tested and it's 10,000, that no one's going to be able to tell you what that means. Are you still protected? Yes, it's lower than normal, but we don't know what that means. And so you're kind of left in this situation with having data that might be, concerning in some way, but you don't actually know if it's concerning. For that reason, the CDC has specifically advised people not to get tested. All of the tests that are out there that are being advertised, if you look at their disclaimers, they explicitly say that they really can't tell you your level of immunity. And I think that, I think in the future that the answer probably will be yes at some point, but we have to have more information to be able to actually interpret the results before everybody goes and gets an antibody test. So if you're not going to do that, what can you do? I think understanding that if you're vaccinated, you probably have some protection. If you were on rituximab right before you got vaccinated or very high doses of steroids, you almost certainly have less protection. You still may have some meaningful protection. And I think really what we need to do is wait for validated tests to understand the right cutoff so that we can actually test our antibody response and maybe even T-cell response in the future. And then I definitely think that booster shots will be coming. And this is already being studied. And I think there's not only will it help to augment the initial response, but some of these booster shots may also incorporate some of the newer variants that are coming out. And then the other question that comes up for those that haven't been vaccinated is, does it matter what you do with your medications around the time of vaccine? And this is guidance from the American College of Rheumatology, which is put together based on what we know from other diseases like rheumatoid arthritis that use similar medications, and studies that have looked at things like flu vaccines, pneumonia vaccines, shingle vaccines, and that data has been extrapolated. I think that, of course, we don't know exactly, because the COVID vaccine, the mRNA vaccines are somewhat of a newer technology, and probably induce a more robust response that can probably overcome some of the suppression from these medicines. But the guidance is to hold methotrexate for 1 week after each vaccine dose, and that we really don't need to modify our use of TNF inhibitors. And that's generally, I think, what most people have done over the last few months. And then one of the other questions that comes up a lot, and this got a lot of media attention, is should you just go ahead and get a third shot? And this story was about a transplant surgeon who is actually a transplant recipient himself, and did, probably through his academic center, some research testing that showed he didn't have much of an immune response, got a third shot, and then showed that it was augmented significantly. So again, I think just as with the antibody testing, I think it is actually a very reasonable question and something to be considered, but my answer right now would be not yet. And I think, primarily because this is being studied, the NIH already has clinical trials underway where they're taking fully vaccinated adults and giving boosters to determine the safety and efficacy. I think it's just very hard to recommend something like this when we have no data to really know if it's safe or effective. And so I think we just have to wait a little bit longer. I do think eventually a booster shot, or potentially just a third shot of something like the J&J vaccine, could be reasonable, but a little too early to recommend something like that. And again, the CDC has kind of firmly said that revaccination is not recommended for patients who were immunosuppressed at the time of their initial vaccination. So current recommendations, I would say, if you haven't been vaccinated, I would highly encourage vaccination. If you are vaccinated, I would feel comfortable that you have at least some protection. I still think it's probably wise to exercise precautions such as masking and distancing. I think we certainly know that steroids, like high doses of prednisone and rituximab, are the biggest risk factors for bad outcomes from COVID and from lack of response to the vaccine. So if you're on those medicines, I think working with your treating physician to minimize or change, if possible. Of course, keeping your disease under control is equally important, and that has to always be balanced. And then I think just keeping up to date, I think we're going to be learning more about hopefully more validated testing to be done, and potential booster shots in the future. And the last thing I just wanted to touch upon, because I know there has been a lot of concern recently about some of these new variants, including the Delta variant from India. All I can say about that, from what we know, a very preliminary recent study showed that the Pfizer vaccine did appear effective against symptomatic disease, about 88%, and the AstraZeneca 60%. We have no data at all on the Delta variant in patients with sarcoidosis. I think there's still lots to be seen there. All I can say is it appears more highly transmissible, but I think we're optimistic that the vaccines will provide protection. So I think key takeaways: are COVID vaccines safe for sarcoid patients? I would say yes. Do they protect sarcoidosis patients? I would say definitely yes. There's probably some degree to that, but I think all the evidence suggests yes. Does your underlying treatment affect your response? That's also a yes. Should you check your anti-spike protein antibody level? Probably not. Again, I think it's a reasonable question, but it would be hard to interpret at this time. There may be a role for that in the future as we better understand what the results mean. And should you seek out a third shot now? I would again say no. But again, I think it's a very reasonable concept that will be evolving over time. And with that, I'll stop and open it up for questions.
Wow, thank you, Dr. Baker. I will say, I'm not sure I have any questions because you answered all the questions. We were actually just going through the questions to see if there was anything that we missed, and I want to encourage folks, because you literally answered all the questions I had on the list. What I would say to the audience, because we just have that 5 minutes left, is if do you need clarification on anything that Dr. Baker presented today versus like sending a direct question? Because you went over everything. So I want to give folks a chance to kind of come back with that. One question that folks had was, well, you kind of addressed this, but we did get a bunch of questions around, again, you did mention sort of masking or continuing precautions.
Yeah.
We just did get a couple questions around, like, should I travel?
Yeah, I think my goal is kind of I think the real takeaway, which I guess I didn't emphasize enough, is that really each person is an individual. And so like the goal is to kind of provide all that data to empower you to basically at this point, each patient on here knows everything I know about their potential risk. And so I think if you're older and you were on 20 milligrams of prednisone when you got the vaccine, and you have, so for each individual, I would make that decision based on what you now know about the risk factors. If you're 30 and you have basically no lung disease from your sarcoidosis and you're on no immunosuppression, I would feel pretty comfortable traveling. Obviously, I would still mask and distance and stuff as much as possible, but I think, for that individual level decision, it's now about kind of taking everything I hopefully taught you and sort of making your own personal risk assessment.
Thank you. We did have a question. You just mentioned 20 milligrams of prednisone. So we did have a question related to, is there a specific dosage of prednisone or steroids that folks should be more cautious about if they're on?
Yeah, I think most of the studies use 10 milligrams as a cutoff for saying you're at higher risk. But I think, one thing that came out of that bigger study of looking at the vaccine response was that it was not dose dependent, meaning they found even patients on 5 milligrams, or even, I think that was probably the lowest, had a reduced 10-fold reduction in antibody response. And so I think steroids are probably concerning at any dose, but the general marker in the field is 10 milligrams, and being below 10 is certainly safer than being above it.
Awesome, thank you. We did have one question that was sort of an offshoot of a previous question, which was around, you do think that maybe masking and precautions, you should still do those things. But is there any extra precautions that people should take, particularly around the fact that, certain states and certain places around the world are opening up again and people are taking their masks off?
I don't know of anything additional that can protect. I mean, I think, I think you have to incorporate that kind of knowledge, though. You have to understand, it's helpful to have some basal understanding of like what the vaccine uptake is in your area. Like if you're in an area where, like I'm lucky in San Francisco area now, it's like 70%, some super high amount have been vaccinated. And if you understand that and you're kind of following the case rates and they're low and things, I mean, that can also play into your decision making. If you're in an area that's opening and vaccine uptake hasn't been great and there's cases, I would definitely take that into account and be more careful.
Thank you. And then our final question today, guys, is should folks wear an N95 mask if they have one, or is double masking a surgical mask just as efficient?
Definitely double masking is not as efficient as an N95. N95s need to be fit, you have to kind of make sure it really fits and you have a good seal and all that. But when that's done, they're almost entirely effective, whereas double masks still aren't entirely effective. But I think for what most people are doing and, most types of exposures, the normal mask or double mask is probably fine.
Great, thank you. And I promise we're going to go a little over here for a second because I have 2 more questions.
Oh,
surprisingly,
sure.
You guys came up with more questions even though we answered all the other ones. So if you had the vaccine and you weren't on steroids before, but you got back on steroids, should you be worried about your ability
Yeah,
to
that's a
have
great
vaccine
question.
efficacy?
That's a really good question. I think that that's hard to know. I think the beauty of the immune system is that after you respond to the vaccine, if it's been 2 to 4 weeks since your second shot, you have cells that are now going to the bone marrow and the lymph nodes and the spleen, and they're kind of taking up residence there. And they turn into these other cells. The B cells turn into plasma cells, which are kind of like long-lived antibody factories, and they just spit out the antibodies. And so for most people, if you then get put on prednisone, you're probably okay because those cells aren't going to go away. And we know that because, for say you get the flu vaccine or one of these like childhood vaccines, hepatitis or something, and then you can look many years later after tons of immunosuppression, those antibodies are all still there because those memory cells are living in the bone marrow and other places and aren't affected. So I think obviously you still want to be cautious, but I think I would feel pretty reassured that if you've been fully vaccinated off immunosuppression and then restart it later, you're probably still protected.
Great, thank you. And our final question today, I promise, is there any extra benefit to wearing a face shield with your mask?
I don't actually, I wouldn't even say I could answer that in terms of like, I have no data, so I don't want to just like speak out of, I probably helps a little bit, but I have no data, so I'm not gonna comment.
Fair enough. Finally, guys, we stumped him on one. So there we go. But you'll get back to us.
Yeah.
Awesome. Well, Dr. Baker, thank you so much for this really informative session. I know that folks are really grateful. I can see it in the messages for your really thoughtful presentation of the data and the information that's relevant to them. And we really appreciate you stepping into this session for us. Thank you very much.
My pleasure. Thanks so much.
Great. All right, guys. Thank you. Have a good day, Dr. Baker.
Thanks. Take care.
Thank you. All right, guys, it is actually break time, and I encourage you all to get out and stretch. It is also the last time of the day that you can get double points for your time in the exhibitor hall. So definitely go ahead and check that out because we'll be giving out our raffle later this afternoon or tomorrow morning, actually. And so we will see you around. Again, my last plug will always be for filling out that survey at the end of the day. You'll be getting that via email later tonight, and we'll see you around at the next session.